Yes, Mr. Keith.
Good morning, my lady. The first witness this morning is Sir Jeremy Farrow, who is joining us online. Sir Jeremy, could you be sworn, please, or give the affirmation, if you follow the instructions from the usher?
Good morning. I'm the usher this morning. Can you hear me?
Yes.
Good. If you would like to repeat after me, I understand you're taking the affirmation. Is that correct?
Correct.
Okay. Repeat after me, please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Could you provide your full name, please?
Jeremy James Farrow.
Sir Jeremy, thank you for joining us this morning. May I commence, please, with your qualifications? You trained, I believe, in medicine with postgraduate training in London, Chichester, Edinburgh, Melbourne, Oxford and San Francisco. You have a DPhil PhD from the University of Oxford. You were a director of the Oxford University Clinical Research Institute at the Hospital for Tropical Diseases in Ho Chi Minh City in Vietnam from 1996 to 2013. From 2013, you were director of the Wellcome Trust, and from May 2023, have you been the chief scientist at the World Health Organization?
Yes, all correct.
And are you giving evidence today in your personal capacity as opposed to a representative of the World Health Organization?
Yeah, it's great. It's very important. I'm here totally in my personal capacity, not represent the World Health Organization or indeed previous lives at Wellcome Trust either.
Have you, throughout your professional career, served as a chair on a multitude of advisory bodies for governments and global organizations? Were you the founding chair, in fact, of the World Health Organization R&D Blueprint entity or body, and the founding director of the International Severe Acute Respiratory and Emerging Infection Consortium, ISA-RIC?
Correct.
And have you received a plethora of honours from a number of governments, institutes and entities?
Thank you.
Could I commence, please, Sir Jeremy, by asking you some questions about the United Kingdom influenza strategy document, the 2011 strategy, about which a great deal of evidence has been received by Milady's inquiry. Are you familiar with that 2011 strategy for influenza pandemic?
Yeah, thanks very much. Can I just start as well by just reaching out with the greatest support for those who've lost lives during the COVID pandemic, affected by the COVID pandemic, families that are still affected and those with long COVID, and particularly also for healthcare workers around the world who put their lives at risk in order to help all of us. The influenza strategy, I think you're referring to, of 2011. In 2011, I was living and working in Vietnam, and so I was not directly involved in the development of the strategy. But it was lessons learned, indeed, after the H1N1 pandemic of 2009. And so I was peripherally involved in parts of it, and also in the Academy of Medical Sciences review of how clinical trials and evidence and data could be gathered in the context of epidemics and emergencies. So peripherally involved in that strategy.
Was there a general awareness of the importance of the strategy to the United Kingdom's pandemic preparedness for influenza?
Yeah, I think if you go back, bear in mind, I've never worked directly within government. I'm sure there are better people than me about talking about how that was perceived in government. But if you go back to the government risk registers over the years, then pandemic influenza would have been in the top risk of many of those risk registers. I do think coming out of 2009 that there was a issue with a sense and this actually is true after many epidemics, I sincerely hope it's not true after this pandemic, that actually 2009 H1N1 was not quite as bad as people thought, and there was a danger globally, including in the UK, of a sort of child that cries wolf, and that actually these were less of an issue than perhaps they would. I think that did influence thinking after 2009 and may have built into why influenza as a pandemic dropped down risk registers around the world after 2011.
There have been a number of references in the course of evidence to the possibility that a degree of complacency was engendered by the H1N1 swine flu pandemic because it was, by the nature of these things, relatively mild. Would you agree?
Yeah, I do agree. I was in Mexico as part of a WHO group in May of 2009, sorry. In May of 2009, the city of Mexico in 4 hospitals within a square kilometre were full of mostly young people with very, very severe influenza. And for many of us who have been concerned and remain concerned that one of the greatest risks is an influenza pandemic of some ilk, going back to 1918, it was entirely appropriate, in my view, in 2009 to raise the flag that this was going to cause a major global problem. In reality, as you rightly say, the severity of H1N1 in 2009 was less than expected. And therefore, I think there did come a degree of complacency that actually the world was safer against an influenza pandemic than perhaps had been previously thought. And there was a lot of criticism at the time about things like stockpiling of the drug oseltamivir. Personally, I think that criticism was unwarranted. And that actually influenza remains, among with others, but remains one of the greatest risks to humanity. And as we now watch H5N1 pandemic in animals circulate around the world in an unprecedented way, influenza is never going to go away as a threat to humanity.
Thank you. So, Jeremy, whilst you give evidence,
Can we slow down?
Could you slow down a little? We obviously want to hear what you have to say, and it's important that your evidence is recorded by our hardworking stenographer, and it's quite difficult if you go too fast. No apologies.
Apologies.
Yes.
It's a nervous occasion to be part of.
Well, it won't be for very long, Sir Jeremy, so I'm sure you'll survive. Milady's heard considerable evidence about the inherent unpredictability of respiratory viruses. And therefore, the inherent unpredictability of the characteristics of a pandemic which may ensue from a widespread pathogenic outbreak. Putting it in blunter terms, it's impossible to know with any degree of certainty what characteristics the outbreak may have, which viruses, respiratory viruses, may eventuate, and therefore what one has to guard against. Was there a general sense at all, as far as you could tell, after 2011, that there had been a failure to focus on, in the government guidance and the government policy in the United Kingdom, on the inherent unpredictability of respiratory viruses, and therefore on the risks of a non-influenza pandemic?
Yeah, I think that would be true in the UK. I think it would be true globally as well. If you go back in the last 20 years, I mean, I started working on emerging infections in 1999 with an outbreak of something called Nipah virus in Malaysia. And
So, Jeremy, please slow down. You're going very fast again. You have to steel yourself to go slower than you otherwise would.
If we look from 1999 to 2019, that 20-year period, and just look at the number of regional or global events that have led to major disruption, SARS-1, which I was involved in Vietnam, H5N1, Zika, MERS, another coronavirus, the pandemic of 2009, and many others as well. It is clear that we're living in an age of a pandemic age where, as Mike Ryan at WHO has said, we're living in an age which is going to have more frequent and more complex pandemics. And yet it is extraordinarily difficult when governments are faced with dealing with the challenges of day to day to also put in place those critical infrastructures, resilience and surge capacity and spare capacity that would allow to deal with the unexpected but inevitable disruptions that are going to occur. So I think in the UK and around the world, despite the warnings of the last 20 years, there has been a complacency about the need to prepare for these sorts of major disruptive events which go well beyond health to the whole of society. And the UK, yes, was complacent in regard to planning for that.
Is it your view that epidemics will become more frequent, more complex perhaps, and harder to prevent and contain as a result of the well-known issues of changing ecology, urbanisation, climate change, and increased travel and movement of human beings?
Yeah, you've hit the major features that I would have outlined, absolutely. These are features of the 21st century. They're not going to go away. It would be a grave mistake, in my view, to see each of these episodes, I've outlined some of them, but there are more, to see each one as a discrete episode. They are telling us something far deeper about how the world is changing. Biodiversity loss, environment, climate change, urbanisation, trade and travel, as you said.
Slow down.
And what I'd like for us to move away from is thinking that this is a discrete episode which we can put in a box and think about, and think more about the systemic way that we need to address these more frequent and more complex events. If we look at Ebola in West Africa in 2014, the Ebola virus had not changed. People had not changed. What had changed was the social circumstances in which it happened, not in villages that could be isolated and quarantined and an epidemic brought under control quickly, but in major capital cities and across borders. And that more frequent and indeed sociologically more complex epidemics and pandemics is what we will face in the future.
Does it follow, Sir Jeremy, that from the vantage point of governments and with a view to the necessary and important process by which risks are identified, assessed and planned for, that there must be a much greater focus now, both in light of COVID and of course because of the increased general risks to which you've referred, upon firstly identifying multiple scenarios as opposed to just influenza. Secondly, focusing additionally on how to prevent catastrophic consequence as opposed to managing catastrophic consequence. And thirdly, thinking more and to a much greater extent about the necessary countermeasures that may need to be deployed.
Yeah, absolutely. First thing I'd say is what you have before a crisis hits will, to a large extent, determine your ability to respond to it. If you have deep inequalities in your society, if you have a large degree of ill health in terms of health issues, if you have health services which are stretched to the limit, if you have fragmented government approaches such that each individual vertical structure considers its area, but there's a challenge to look at the all of society perspective, then trying to cobble together a horizontal approach, an all of government and all of society approach in a set of vertical systems is extraordinarily difficult. And tabletop exercises will get you so far, but you need to be working in those systems all of the time if you want those systems to work when a crisis hits. And I think we need to think more strongly about how totally disruptive all of society events, of which this is a good example, will be dealt with at a cross-government, whole of society approach rather than just as a single ministry approach.
A vital component in the whole of society approach is, of course, having adequate scientific advice, as well as and alongside a adequate and sufficient research base. Could I focus firstly, please, on the issue of the scientific advisory networks which are available in the United Kingdom? You were a member of SAGE, the stand-up, that is, say, a committee which is stood up in the event of emergencies in relation to Zika and Ebola. Is that correct?
Correct.
And have you had extensive experience throughout your long career of dealing with the scientific advisory structures in the United Kingdom beyond SAGE?
Yes.
Evidence was given by Professor Sir Chris Whitty that the UK science advisory system, whilst complex and not perfect, is considered to be one of the stronger ones internationally. Would you agree?
Yes.
What must be done to ensure that that remains the position in terms of resourcing or funding or a continuing focus on understanding the vital importance of scientific advice?
So I would agree with those comments, and I've been involved in some of your introductory remarks with a number of other governments around the world of all economic levels of growth and depth of scientific background. My view is that the construct of having a chief scientific advisor in every ministry, close to the minister, close to the system, close to the senior civil servants, not just structured in a crisis, but there every day, and learning to bridge the cultural and language complexity that is there within different disciplines and different ways of working and different educational backgrounds and everything else. Building that structure to be permanent, to be functioning all the time, and critically providing value and utility to a government machinery all of the time is, I believe, critical. And I've argued with many other countries, discussed with many other countries that actually the UK system of scientific advice in every ministry brought together under a chief scientist, networked together, providing mutual support to each other is absolutely critical, must be maintained, must be strengthened. The very best people in science should be encouraged to go into it and on a rotational basis so that they can retain their scientific expertise and skills and then network together through the chief scientist. That, to me, is the best system in the world and everything should be done to maintain it, not for crisis time, but for all the time, to deal with the day-to-day issues as well as be able to respond when a crisis inevitably hits.
It's plain, Sir Jeremy, that in the particular context of dealing with the COVID pandemic, SAGE and the scientific advisory structures in the United Kingdom government drew to a very large extent, of course, upon biomedical expertise. Because of the need to consider at speed and in very difficult circumstances that the consequences of societal measures, social restrictions, mandatory quarantining and so on and so forth. It may be the case that there was an absence of sufficient expertise from non-biomedical professionals, that is to say economists and behavioural scientists or social scientists and experts, not from the world of health and not from the world of science, but from the social sciences. Would you agree with that? From your experience of SAGE, do you think that it is, in a general sense, sufficiently diverse?
So I would agree with some of that, but not all of it. Firstly, I think that SAGE is often seen as the names officially on the SAGE list, which I think counts to 30 or 40 people or so. Behind that, there were hundreds of people involved, and particularly on some of the areas you mentioned there, behavioural science, for instance. I think the input into the behavioural scientists into SAGE from throughout my time on Sage, I thought was of the very highest quality. Where I do agree with you is that there were two things lacking in my view. One is the Sage health, public health, behavioural science perspectives on the pandemic were not mirrored with other equally transparent and debated issues that brought the whole of the society elements together. And I believe, I've never been in government, but I believe that a better approach would have been to have a Sage that focuses on its area of expertise, definitely including behavioural science, international perspective, ethics, many of the things you mentioned. But that would be mirrored, in my view, through the Cabinet Office with a similar transparent expert group that would consider other aspects that are absolutely critical to an all of society response. I think if you ask Sage to do all of that, it would become huge, unwieldy, and wouldn't be able to have the clarity, given in mind that Sage was meeting at some point every 24 or 48 hours. So personally, I would do that through the Cabinet Office, but have equal transparency with elements that considered other aspects beyond the health agenda. And the second thing I would suggest, and I was part of this in a US group, is that there is outside the Sage system, but linked to it in a constructive way, if you like, a red team. A red team that would have access to the same information, but would be able to constructively challenge the thinking from the outside and wouldn't be within the room at the same time. I thought that worked extremely well when I was part of a similar enterprise in the United States. And I would like to see that set up. Independent Sage, I think, tried to do that, but unfortunately, for reasons others can debate, sometimes it became more confrontational than perhaps was constructive.
A red team would plainly be in a position to challenge orthodoxy. Do you mean orthodoxy on the part of the government, or orthodoxy, or alleged orthodoxy on the part of the scientists in Sage or a mirror group, who I think I should tell you have described themselves in this inquiry in various terms, such as being self-correcting, or on another occasion as being licensed dissidents? Do scientists need to be challenged in that way, or is this a point made more directly against administrators and government employees?
Science absolutely has to be challenged, and I think, unfortunately, I'm not aware that beyond the summaries then released, I think at the behest of Patrick Vallance, crucially. It's a shame that actually Sage wasn't recorded in some ways, because I think within the Sage discussions that I was always part of, there was a very high degree of challenge. But to have an outside group, a red group, that just puts in questions, have you thought about this, have you thought about that, have you considered that, who are not part of that formal group, I think my own experience of that is from the United States, and there I thought it was very helpful to be able to do that. It doesn't diminish the authority or the voice of Sage, but it would give you some of that external challenge. I think within the Cabinet Office, to me, that is where the political challenge of is this the right thing to do, closing schools, closing economies, whatever it might be, should be held. But I think those need also to be transparent in the same way that Sage was with its minutes and summaries, so that people can actually, as the public, can actually challenge those assumptions as well.
All right.
Mr. Keith, are you going further into the mirror group?
No, I was going to move to the question of specialist committees.
Just have a brief summary of what Sir Jeremy means by the mirror group, which experts, how would it work?
Yes, so Sir Jeremy, a few moments ago, in response to a question from myself as to whether or not the constitution, the makeup of Sage was sufficiently diverse, you suggested the possibility of a mirror group, not as part of Sage itself, because it would become too unwieldy and too large to be convened at speed and in very difficult circumstances, but a separate committee comprising experts, specialists from different professional walks of life. Could you expand on that? You referred to social scientists, economists, and others. Is there anything more that you want to say about that in terms of its composition?
Well, I think the social scientists and behavioural scientists were absolutely fundamental to Sage itself. So I certainly But I think a group outside of what I call a red team that was able to throw in questions into Sage. Have you thought about this? Have you thought about that? Some of that happened informally through things like in the UK, the Royal Society, Academy of Medical Sciences, etc., and obviously in the lay and scientific literature. But I, having been part for some time in the US of that red group, which brought together, yes, epidemiologists, biomedical people, social scientists, economists, people thinking outside the box, that was helpful, I think, in terms of the US approach to this, which I have to say, I believe was not as well constructed and organised as was Sage, would be my view, having seen both operating.
So those specialists and scientists and professionals are, in terms of their own professional qualifications, mirror images of the constituent parts of Sage. They're not from other walks of professional life. That they are there to challenge, if you like, the members of Sage on their own turf. No,
I wouldn't. No, sorry. Let me clarify. I think in that sort of red group, you could easily have a broader sector of society, civic society, industry, people, yes, with expertise and understanding of public health, but also others who would bring a different perspective.
Right. So, Jeremy, can I ask you now about your experience, please, of some of the more specialist scientific committees concerned with pathogenic outbreaks? Have you had dealings over the years with HARES, the Human Animal Infections and Risk Surveillance Committee, or ACDP, the Advisory Committee on Dangerous Pathogens, or on the now abolished NEPNI? Are those committees, although you weren't in government, with which you've had any experience?
No, I was not part of any of those. The greater experience I had was actually outside the UK, as you mentioned, being the founding chair of the WHO R&D Blueprint advisory and WHO committees and the other governments, but I was never involved in any of those that you mentioned there.
All right. You've referred in the course of your evidence to the growing risks of pathogenic outbreaks, particularly of the viral respiratory kind, and to the growing risks generally because of changes in our environment and our way of life. To what extent is it essential to meet those continuing and growing risks that we maintain as a country capability, that is to say, the medical, scientific and social weapons at our disposal to meet a future pandemic?
So I started off by saying what you have before a pandemic or any crisis hits makes such a huge difference. There are many things to question and challenge, and that's the role of the public inquiry in terms of the pandemic. But I think we can only celebrate the remarkable scientific, and by scientific I mean the broad sciences, contribution to the pandemic in the UK and around the world. That you can't turn that on in a crisis. We didn't make a vaccine in 12 months. We made a vaccine because for years before, all governments in the UK of any colour, I would argue as well, the Wellcome Trust, the charitable sector, philanthropy, have invested in basic science, in people, in teams, in institutions. And if you look through the development of the Oxford AstraZeneca vaccine, if you look at COG UK, building off years of work at the Wellcome Genome Centre, if you look at the recovery trial, if you look at when local authorities and others through public health got involved in their communities through ownership and knowledge of those communities, those were absolutely world-leading. Those are the results of decades of investment in fundamental science and its translation. A brilliant regulator. MHRA now, and when it was part of the EMA, is one of the world's, if not the world's best regulator. They were critical, understanding ethics. So this infrastructure in the UK is something the UK should be incredibly proud of, must maintain, and has a critical role to play internationally.
Is that a capability without which it is impossible to scale up the necessary medical and clinical responses in the event of a pandemic? Is that something which must be maintained, because without it we would not have the building blocks to be able to mount a defence in the event of a pandemic?
Absolutely agree with that. As I say, the vaccine was not made in a year. If you don't maintain that capacity, and if that capacity isn't valued, isn't funded, is not providing value and utility all of the time. We should remember that the Oxford AstraZeneca vaccine came off a team, Sarah Gilbert, Andy Pollard, and many others have been working on MERS vaccines, they've been working on typhoid vaccines, they've been working on meningitis vaccines, and were able to pivot. The recovery trial built off years of investment, particularly from the National Institute of Health Research and the clinical trials capacity. These are absolute jewels in the UK's crown. They could play, in my view, a bigger role internationally, but you have to maintain them every Monday, every Tuesday, and you have to value them, and they must provide value either in enhancing knowledge and our understanding of the world, or in translation into products, countermeasures for people in a pandemic. If we do not retain that scientific infrastructure, then the UK will be woefully underprepared to deal with today's challenges and tomorrow's inevitable epidemics.
Does that infrastructure include matters such as having sufficient laboratory services, for example, to be able to scale up mass diagnostic testing in the event of a new pandemic and perhaps a different testing device? What sort of laboratory infrastructure is required to be able to provide that building block to enable us to scale up in the next crisis?
The testing capacity in the first 3 months of 2020 in the UK was woefully inadequate. It wasn't possible to scale that up at the speed that was required, and testing got way behind the speed of the epidemic. And in epidemics and pandemics, there is no point saying we're quicker than we used to be if you're slower than the speed of the epidemic. And if you get behind that curve, you'll really struggle to catch up. Remembering that exponential growth, doubling time every 2 days, means even 48 hours later, you've got behind the curve. And the data you have today is in the rear view mirror. It's what happened yesterday that you're seeing, not what happened today. So unless you have that diagnostic capacity, I would personally like to see a much closer interrelationship between what we call public health laboratories, clinical and NHS facilities, and the broad and very strong research environment in the UK. Often these are almost competing with each other rather than seeing themselves as part of a common approach. And I think to forge together public health laboratories, local authorities, hospitals and clinical facilities, general practice, primary care, and the research endeavour, and make sure that those are working together outside the pandemic and can much better work together in a pandemic, would be a huge progress in terms of our ability to have the resilience in the future.
So drawing those threads together, Sir Jeremy, would you agree that both in terms of research capacity, but also infrastructure, laboratories, technicians and the like,
yes,
it is vital, I'm sorry, I haven't quite finished. It's vital that capability is maintained for both, for not just diagnostic testing, but antivirals and also vaccines, to which you've referred. So this is a capability which must be maintained across the board for those three pillars, if you like, of pathogenic outbreak response.
Yeah, I would actually add to that. The social science, the behavioural science must be integrated as part of that, not some separate thing that goes on in other conversations. But we must maintain that all the time. The only way to maintain it, and if we're not to repeat the lessons of all of the epidemics I mentioned at the start, the only way we can maintain this is if it is integrated into services and health provision, prevention and treatment every Monday, every Tuesday, every week, every month. Because after every previous epidemic, after Ebola, the world said, never again. We must build these capacities. And sadly, 1 or 2 or 3 years later, the pandemic hasn't happened and they start to be cut. So my view is, instead of creating yet more vertical structures that will somehow be there when a pandemic strikes, build it into systems that are of use every day, people are using them, they provide value to communities, and then they can pivot when it's necessary. If we look at COG UK as a good example, established by Sharon Peacock, it was building off years of public health interest in genomics and the Wellcome Trust Genome Centre and institutes like the Crick, Edinburgh, Glasgow, Manchester and others, Biobank. These are critical infrastructures. They're providing value and utility all of the time, and they have critically the people who can pivot when necessary. We must not lose this capacity.
Turning now finally to a more administrative or governmental angle and the issue of countermeasures. Is it your view that further work is also required to be done in terms of thinking about, evaluating, working out the consequences of the policy interventions with which we're now all only too familiar, such as quarantining, social distancing, the efficacy of face masks, airport screening and so on, all of which, of course, came very much into focus during COVID, but perhaps have not been developed in terms of the thinking as far as they might be.
Yes, I do agree with that. And having listened to some previous interventions and the concern that everything was based around a potential flu pandemic and no other thinking, things I would say on that, flu remains the number one biggest risk. But we should be thinking beyond flu in terms of a crisis management system that would be agnostic to what the event was. And it could be respiratory, most likely, it could be sexual, it could be through the gastrointestinal. So there's all sorts of scenarios. And instead of getting plugged into a single outcome, which we feel comfortable with, perhaps more important is to think, whilst we will focus on flu because it's hugely important and is the highest risk, and it remains so, that nevertheless we must have a system which allows us actually to cope with whatever is thrown at us and have the resilience and the spare capacity and not the whole system stretched to its very limit in order not to be able to respond when the demand increases. So I would like to think more broadly, more like an incident management group than a flu-specific group, without losing the knowledge that flu remains a huge risk to us all. And those policy interventions that you talk about need a discussion at societal level. The word lockdown, none of us had heard of it before about February or March of 2020. The implications of it are huge and long-standing. We should be able to debate those in the inter-epidemic periods and come to a societal discussion about what we're going to prioritise, what we're going to protect, and what we may have to do in order to prevent an event like COVID-19 happening again.
So, Jeremy, thank you very much. My lady, I believe you granted permission to Welsh COVID bereaved for an issue or issues surrounding the question of face masks to be explored through my own examination. Is that right? So, Jeremy, could I return you, please, to the question of face masks? The issue of face masks and their efficacy is very much going to be a matter for consideration in my lady's module 2 in this inquiry, because, of course, there was a huge debate about face masks once COVID had hit. But in the context of preparedness, may I ask you this? To what extent, pre-COVID, was the wearing of face masks an issue which was thought about, sufficiently developed, and views reached upon? And an associated question, to what extent was there pre-COVID a scientific consensus on the efficacy of face masks, putting aside how effective they actually were? So, was there a standing scientific consensus on the efficacy of face masks pre-COVID, and to what extent had thinking on face masks developed pre-COVID?
Well, I think in the UK that consensus did not exist. And the effectiveness as well as the efficacy of face masks, I do not believe in the UK there was a consensus on that. Having spent almost 20 years living in Vietnam through SARS and H5N1, and then watching very closely and being very involved in the responses in China, in Korea, in Vietnam and Singapore, 4 countries that had previously dealt with SARS-1 and with other emergencies, I think if you ask there was a clear consensus amongst the decision makers and indeed the scientists and healthcare workers that face masks had a role in contributing to the public health intervention. In public health, there is rarely a magic bullet. Public health, the analogy of the Swiss cheese model of having multiple interventions is crucial. If you're expecting face masks to give you 95 protection against something, you won't get it. But as part of a series of interventions, which includes face masks, includes hand washing, and includes clean air and spacing between individuals, and then when you have the countermeasures you're talking about, diagnostic tests, treatment and vaccines, together they create a Swiss cheese model of how public health is. Each one contributes a percentage. None of them on their own contribute enough to change the dynamic of a pandemic, but together they can have a very profound impact. And when you talk about countermeasures, often we talk about countermeasures in terms of therapeutics and vaccines and diagnostic testing. The countermeasures need to be seen in the full Swiss cheese model. They need to include social distancing. They need to include masks. They need to include hand washing. They need to include in other epidemic potentials, other interventions, for instance, in HIV, condoms, etc. So I think we would be wiser, and the evidence base on face masks, unfortunately, was we had large clinical trials for therapeutics, the recovery trial, we had the vaccine trials. We missed an opportunity during the pandemic to gather robust, strong, prospective data on non-pharmacological interventions, which are a critical component of any response to an epidemic and pandemic until you have those countermeasures that will then change the course of the pandemic. So what I would plea for is we don't see countermeasures just as something you inject into somebody's arm or you take as a tablet, but we see countermeasures in a Swiss cheese model of public health, which integrates them all, and we find the evidence for how they work on their own, and we find the evidence for how they work together.
So, Jeremy, thank you very much indeed.
So, Jeremy, thank you very much indeed for your help. It's been extremely interesting, and we're very grateful to you. Thank you.
I wish you the very best with the public inquiry and offer all the support we can to it. The lessons must be learned, and we must never be there again.
Thank you.
My lady, I think that we can proceed to the next witness straight away. If somebody would be good enough to sever the link with Sir Jeremy, we'll return to the witness box.
Just before Mr. Sturgeon gives evidence, I'd like to apologise to those who were inconvenienced by the fact we didn't call Miss Calderwood on Wednesday morning. It was due entirely to unforeseen circumstances, and I can assure people we gave everyone as much notice as we could and as we got, in fact. So,
My lady, yes.
Apologies to anybody. Mr Keith?
Could the witness be sworn, please?
Repeat after me. I do solemnly,
I do solemnly,
sincerely and truly
sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Thank you. Welcome.
Could you give the inquiry, please, your full name?
Nicola Sturgeon.
Ms Sturgeon, thank you for offering your assistance and providing it to this inquiry. But whilst you give evidence, could you please remember to keep your voice up so that we may all clearly hear what you have to say, and also for our hard-working stenographer so that she can record your evidence.
Excuse me, my lady, with your permission, would it be possible to say a few words by way of introduction?
You may.
Thank you. I'm appearing at this public inquiry for the first time, and as the First Minister of Scotland for the duration of the pandemic, I wanted to take a brief opportunity to offer my sympathies and condolences to all those who have suffered as a result of COVID-19. The pandemic may be over, but for very many people that suffering continues to this day, and there is not a day that passes that I don't think about that. Secondly, I want to convey my thanks to all those who contributed to the national response, obviously to our health and care workforce, but to all of those across the public, voluntary and private sectors. And of course to the general public, who did everything that was asked of them and made extraordinary sacrifices. Finally, my lady, I know that every day the government I led did our best to take the best possible decisions, but equally I know that we did not get everything right. The learning from the pandemic is of critical importance, and this public inquiry has a central role to play in ensuring that those lessons are learned, and therefore I appreciate the opportunity to be here before you for the first occasion today. Thank you very much.
Thank you, Ms Sturgeon. You say the first occasion because, of course, it's known to my lady, but not necessarily the wider world, that you will be giving evidence again before this inquiry for the purposes of Module 2A, which will be the module that will be more particularly concerned with the response to the pandemic once, of course, it had struck. Ms Sturgeon, you've provided kindly a witness statement dated, I think, the 19th of April 2023. We needn't bring it up, but it's a witness statement to which you have appended your signature and a statement of truth. Is that correct?
That's correct.
You were, of course, as you said, the First Minister of Scotland, but earlier in your career, you were Deputy First Minister and Cabinet Secretary for Health, and coincidentally, that was during the swine flu pandemic, which hit the United Kingdom in 2009. Is that correct?
That is correct.
And so you would have become familiar with the exquisite difficulties of dealing with the onset of a pandemic on a country and familiar with governmental response.
Yes.
Just to get our bearings, that pandemic, H1N1, as we've heard, was, by the general standards of these things, relatively mild, was it not?
Yes, indeed. Milder, thankfully, than any of us had expected at the outset of it.
There were some 1,500 hospitalisations in Scotland, fortuitously no deaths, I believe, but of course there were around about 17,000 deaths globally. There may therefore be a limit as to what lessons could have been learnt from that milder pandemic. But the Scottish Government commissioned a paper, did it not, to review its own response to that pandemic.
We did, yes.
And was that a report or a paper that you yourself commissioned?
Yes, I believe I would have commissioned that as Health Secretary at the time.
May we have, please, that paper on the screen, 102936. It's headed Cabinet Subcommittee on Scottish Government Resilience, Influenza H1N1 Pandemic Review of the Scottish Government Response, and it was a paper by the Cabinet Secretary for Health and Wellbeing. You were Deputy First Minister and Cabinet Secretary for Health, and therefore may we presume that was you?
I'd have to check the date of it to see whether I was still Health Secretary when that paper was produced, but I believe that would have been me, yes. Mm-hmm.
I think the paper was produced in 2011. You were Cabinet Secretary for Health until the 19th of May 2011.
I was Cabinet Secretary for Health into late 2012.
Yes.
That would have been me in that case.
Yes. You were Cabinet Secretary for Health until the 19th of May 2011, and then you became Cabinet Secretary for Health, Wellbeing and City Strategy thereafter.
Thank you for reminding me.
Page 5 of the report refers at the bottom of the page to planning assumptions. Respondents recognised the limitations of modelling. However, it was felt that it would have been helpful to have updated the planning assumptions more quickly to reflect the picture on the ground, in effect reflecting the most likely scenario rather than the worst case scenario. Respondents felt it would have been helpful for the process of testing the planning assumptions to be more explicit. The planning assumptions which were published did not hold much weight with responders on the grounds that they did not reflect what they were experiencing. Ms. Sturgeon, these references to the planning assumptions and to national and local responders' views as to how efficient or how useful that they were, was that a reference to the broad governmental system by which risks are assessed, grouped together, and assumptions made for the purposes of planning as to how those risks should be addressed?
So my reading of these paragraphs, and forgive me, I would need to see these paragraphs in the context of the whole paper to be certain that what I'm about to say is correct. But certainly in relation to the second bullet point there, what that seems to me to reflect is something that was certainly true in the handling of the H1N1 pandemic, is that the pandemic did not unfold in the way that the plans and the modelling and the reasonable worst case scenario estimates had indicated that it would. And that had relevance, I think, to what we learned about the strengths and weaknesses of pre-pandemic planning. So my reading of that is that that was a statement about the gap that opened up during the swine flu pandemic between what the plan told us would happen and what in reality happened.
That issue, the divergence between risk assessment, plan, identification of response, and the reality of a pandemic, was an issue that continued to bedevil this area of strategy planning, did it not?
Yes, it did. I think that is fair comment. I also, having now in different capacities, as we've been covering, been involved in the response to two pandemics, I, to some extent, think that there is an inevitability about that being a problem that will always exist to some extent, because there is no plan that will ever completely replicate what happens in reality when a pandemic, unfortunately, confronts us.
Indeed. At page 11, relatedly, in the middle of the page, there is this heading, actions to be taken forward as part of the UK-wide review into the influenza A H1N1 response. Was that a reference to the review which was carried out, in fact, by Dame Deirdre Hine?
That would have been a reference to the Hine review, yes.
We'll oversee the work of the review team through Scottish Government representation on the reference group. We'll consider the implications for Scotland of the emerging findings, specifically those relating to, and then the bottom bullet point, future iterations of the pandemic flu framework. Was that reference to pandemic flu framework a reference to the then pre-existing Scottish strategy for dealing with pandemic flu, and also the prospective, the anticipated United Kingdom strategy for dealing with influenza pandemic, which we'll come to in a moment?
So I suspect that would have been effectively both of those things. It would have been a reference to whatever pandemic flu framework was in existence at the time, the pre-existing Scottish Government one, and then what became the UK-wide pandemic flu preparedness plan in 2011.
Thereafter, Ms Sturgeon, as my lady has heard in the course of evidence, under the Four Nations approach, the United Kingdom drew up and disseminated a new 2011 strategy, and that is, or became, the sole strategy for dealing with pandemics. And it was, of course, a strategy which on its face dealt only with influenza pandemic. There was a commitment there in that review by the Scottish Government to keeping future iterations of the pandemic strategy under review. But to a very large extent, that did not happen, did it?
The 2011 Four Nations plan was not updated. Now, for that to have been updated on a Four Nations basis would obviously have required the engagement of all four governments. In my view, and this takes us to the heart of some of the most important lessons I learned from the swine flu pandemic, had that plan been updated, I do not necessarily think it would have changed substantially. I think I heard Professor Sir Chris Whitty make a similar point to you last week. That a review, refresh, different iteration of that would not have changed necessarily the fundamental assumptions or planning or modelling at the heart of it. In brief, the two lessons that I took from swine flu in relation to plans were firstly, and I've already touched on this, the importance of any plan being adaptable and flexible when it first confronts reality. In summary, what happened in swine flu was that as the pandemic thankfully turned out to be milder than we had anticipated, there was a period when the governments tried to make the pandemic fit the plan rather than adapt the plan to the pandemic. So flexibility is the first point. The second point, I guess, relates to that, is the importance of whatever is on the paper in the form of a plan, there is work done to operationalise and test that plan. I'm sure we'll come on to some questions around exercise Cygnus on a UK basis, Silver Swan on a Scottish basis to a lesser extent, because it was looking at MERS, SARS rather than flu, exercise IRIS. But the work that was done through these exercises and the work in Scotland that was done by local resilience partnerships sitting underneath our regional resilience partnerships, in my view, was more important than having tweaked versions of a plan that was only ever going to be a template for the situation that we ultimately found ourselves dealing with.
As it turned out, Ms Sturgeon, the reality was that the plan, the strategy, the 2011 document required not just tweaking, and it may well be that it wouldn't just have stopped at tweaking had it been significantly revised. It was, and has been described by a variety of witnesses, as wholly inadequate, strategically. And do you accept that there is now a much clearer understanding as to the nature and the degree of the inadequacy of that document?
So yes, and if I may, I'll perhaps try to break that down briefly into two parts.
Please.
And perhaps give a little bit more explanation for my use of the term tweak. Had a process to update that plan focused on updating an influenza preparedness plan, I can't be sure about this, but I do not believe it would have changed significantly, because it would still have been a plan dealing with the potential for a flu pandemic. Had it been a process designed to turn a flu plan into a plan that was looking at a different range of pandemics, that may have been a more substantive exercise. In terms of your question, do I accept that the plan was inadequate? In summary, yes, the plan was for a different type of pandemic than the one we unfortunately were confronted with. What I would say in addition, though, is that that does not mean no part of that plan was useful in any way, because some of the consequence planning for a pandemic, I mean, there are some, as we know, and we'll come on to no doubt today and in future modules, significant differences with significant consequences between flu and what we ended up dealing with in terms of a coronavirus pandemic. But some of the consequences were similar. So I would, I guess, push back a little bit against the notion that there was nothing in the flu planning that served us any purpose at all when it came to COVID-19.
You would accept, I think, that there was no plan for non-influenza pandemic, at least on its own face, correct?
That is absolutely the case. That is not to say that there was no thinking within governments around non-influenza diseases, high consequence infectious diseases. Exercise Iris, which was a Scottish Government exercise, looked at that specifically. What there wasn't, and I think this is the significant gap, is there was no set plan, which, as I say, is not the same as saying there was no thinking into how we dealt with a pandemic that had features and characteristics of flu in terms of transmissibility, but also the severity and what we came to understand in terms of the asymptomatic transmission of COVID-19. So if you look at Exercise Iris, it was looking at a MERS-SARS type incident, but not a pandemic, one that was small and very contained. Yes. So I would readily accept that there was a gap in terms of the pandemic we ultimately were dealing with. But as I say, that does not mean the plan that was in place had no utility at all.
No, and I'm not suggesting it had no utility. The plan on its face called for flexible application. It called for flexibility. It proclaimed the fact that viral respiratory pathogenic outbreaks are by their nature inherently unpredictable, and therefore that the plan should be applied to non-influenza pandemics. But there was no development of that thinking, was there, in the plan? There was no debate about what those inherently unpredictable characteristics might consist of, the differences in the transmission rate, or viral load, or severity, or incubation period. That's correct, isn't it?
That is correct. That said, and I obviously I'm not a scientific clinical expert in any way, shape or form, but it may have been difficult to capture the range of possibilities that you've just alluded to there in a single plan. I think the other point I would make about the utility or otherwise of plans, had the flu plan been reviewed and turned into something that was looking at pandemics or the potential pandemics more widely, whether that plan would have served its purpose would have depended on the capabilities that lay underneath that plan. So I'm straying slightly perhaps into future modules here, but for me the questions in my mind, literally every day, are not so much did we lack a plan, but did we lack the capabilities for dealing with a pandemic of the nature of COVID-19? And obviously I'm talking there about contact tracing, testing infrastructure in particular.
But you would accept, Ms. Sturgeon, that had the plan focused more plainly, more clearly on the inherent unpredictability of viral respiratory pathogens and their characteristics, and identified that the next pandemic might have different characteristics to influenza in terms of transmission rate, incubation period, viral load, severity, it is likely there would have been a much closer and clearer debate about the necessary countermeasures. For example, mass diagnostic testing, mass contact tracing, social restrictions, quarantining, and so on. And that debate was wholly absent, wasn't it, from that strategy and from all the contemporaneous material?
Much of that, yes, I was absent from that. So I do think that is fair. And yes, with retrospect and in hindsight, I think we would all have benefited from much earlier discussion around some of these things. I suppose the only point I'm making, maybe this comes from too many years in government, not now, obviously, is I think there is a real danger in putting an overemphasis on plans. There is often a tendency in government to say, well, we have a plan, it sits on the shelf, and so we've done the preparation. And it's what, as I think you're putting to me fairly, it's what lies underneath that. And had there been a plan that looked at the range of pandemics other than flu, then yes, it is possible that we would have had greater discussion around some of the elements that, of course, came very much to the fore when COVID struck.
The reason I put the question to you, Ms. Sturgeon, the way that I did, was to respond to your suggestion that the acknowledged strategic flaws in the plan may not have mattered because what matters more is capability.
Absolutely.
My point to you is, had there been a proper development of the issues of the required countermeasures necessary to meet properly identified risks of non-influenza pandemics in that document, that capability is likely to have been better developed by the time COVID struck.
I think that is fair, and I would accept that. I think it would come down to how precise some of those other predictions or models had been. But I think that is a fair comment to put to me.
And your point about the danger in government of selecting a plan in the reasonable expectation that it will do what it says on the tin and it will meet the need of the exigency or emergency which has arisen. Would you agree that that plan tended to focus upon managing the catastrophic consequences of a pandemic influenza as opposed to trying to prevent those catastrophic consequences from developing in the first place?
I'm not sure I do entirely agree with that. And again, I'm perhaps straying from your question being anchored in the flu preparedness plan and projecting a little bit to some of the commentary that's been made around the handling of COVID. I suppose there is a question in my mind in the context of a pandemic. What do we mean by prevention? I think there is a question about whether any single country at a population level could prevent, i.e. stop a pandemic happening. Clearly there are measures at an individual level that people try to take to prevent themselves getting it. But in the context of a pandemic, it is, and I can only speak for myself and the Scottish Government here, it was never the case when COVID struck that we just accepted as a given that a reasonable worst-case scenario was going to unfold. It was our determination from the outset to do everything we could, and I think this is what prevention means in the pandemic context, to suppress it to the maximum. The questions, I think, that are really important for us all to consider, very, very frankly, is could or should we have done more to suppress to the maximum COVID? But speaking on behalf of the government I led at the time, it was never the case that we simply accepted there is a level of harm that is going to be done by this virus, and we accept that. We were always, in fact, it became later on one of the points of difference between the Scottish and the UK government, the extent to which we were still seeking to suppress as opposed to live with the virus. So I don't accept that there was ever, certainly in my mind, an acceptance of a level of harm that we were willing to have unfold.
That was not, however, my question, Ms. Sturgeon. My question revolved around the strategy and whether you accepted that one of the unintended consequences of that strategy was that it tended to focus administrative concentration on trying to deal with the consequences of a catastrophic emergency rather than preventing it in the first place. For example, you've already acknowledged that the absence of thinking on the two main methods by which catastrophic consequences can be prevented, mass diagnostic testing and mass contact tracing, were wholly absent from this strategic debate.
So forgive me if you thought I wasn't answering your question. I was seeking to try to answer your question, but I perhaps went on to COVID more than the flu plan. I think one of your questions, which is reasonable, is the flu plan was looking at flu. And so some of what would have been perhaps in that plan, had it been looking more widely, was not there. What I was seeking to address was this notion, either in the flu plan or later in COVID, that there was simply an acceptance of a level of consequence. I think, forgive me, I can't remember the precise text in the 2011 flu plan, but I think there is commentary in it that reasonable worst case scenario are not necessarily things you accept. They don't take account of the countermeasures that you take to try to reduce that. So either in that plan or in the eventual handling of COVID, speaking from my own perspective, it was not simply here's a level of consequence that we accept that we can't do anything about. I do think, and this goes to your point about mass testing and contact tracing, the question, very legitimate, is could or should we have done more to put ourselves in the ability of suppressing? It is also the case that I don't think for any responsible government it can ever, in a context like this, be either trying to suppress or dealing with the consequences. You have to do both, and that is a feature of the planning as well.
I'm going to put that over to Module 2A, Ms Sturgeon.
Forgive me.
But in relation, therefore, to the strategy, we appear to be agreed that the strategy, because it proclaimed its ability to be applicable to non-influenza pandemics, whilst it proclaimed its ability to be flexible and applicable to non-influenza pandemics, simply did not provide the thinking or the tools necessary to be able to deal with them. I'm not asking you again about, and I'm not seeking your answer in relation to how the Scottish Government did respond and what its approach was once it was struck by the pandemic, but in terms of the strategizing, the planning and the preparedness at an overarching level, that thinking and the development of the necessary tools was absent from the sole strategy document that was meant to be applicable.
I think that is fair, yes.
Right.
We're going to be break. I'm sorry, we have to take a break every so often, Mr. Sturgeon, for the stenographer. Would that be a suitable?
Very suitable, thank you, my lady.
Right, I shall return at 11:30.
All right.
So, Ms Sturgeon, having been harnessed to the 2011 strategy, Scotland was, of course, aware that that strategy was required to be refreshed or updated, and you are aware, are you not, that one of the work streams which was assigned to the Pandemic Flu Readiness Board in London and to the Pandemic Flu Preparedness Board in Edinburgh was the job of updating that strategy, and it never came to pass.
That's correct.
And you agree that the reason why it never came to pass was that it was one of the work streams which was recognised to be necessary to be done, and because of the diversion of time, energy and resources to the necessary preparations for a no-deal EU exit, it happened to be one of the work streams that was paused.
Yes, that is correct. The prospect of a no-deal Brexit and the work that was required across all of the UK governments to plan for Yellowhammer assumptions meant that a significant amount of time, energy and resource was diverted into that from a range of other matters, and that was certainly one of the work streams that suffered from that. We may come on to this, so I won't go into detail right now. That is not to say there was not continued work in the Scottish Government to prepare for a pandemic, although, as we've already covered, much of that was in the context of a flu pandemic.
As you've rightly acknowledged, and as your then Director of Safer Communities, Cabinet, Director of Safer Communities, Gillian Russell, accepts in her witness statement, a very significant amount of emergency planning time was spent on planning for a no-deal EU exit, and therefore something had to give. And one of the things that had to give was some of the work that was meant to be done for emergency planning. May we ask you, to what extent was that difficult decision, the diversion of resources, debated at cabinet level? It's apparent from a large number of documentation that the necessary diversion was ventilated at administrative level, was acknowledged and accepted, and officials just had to get on with the job in hand with the resources that they had. But to what extent was that brought to your attention for the ultimate decision as to whether or not that diversion of resources away from emergency planning was appropriate?
So I was very aware of the necessity to divert resources from other priorities to plan for and look at the potential for a no-deal Brexit. It wasn't the case, to the best of my memory, that somebody came to me and said we need to divert resources from pandemic preparedness to this. But I would have known that there were many other aspects of emergency planning that had resources diverted for them. The Scottish Cabinet discussed no-deal Brexit, Brexit generally, and the potential for a no-deal Brexit on many different occasions. Brexit obviously was something that was happening completely against the will of the Scottish Government, so we were not at all happy about what we were having to do. But to put it bluntly, we had no choice, because had a no-deal Brexit happened, and there were periods over 2019 where that was a distinct possibility, the consequences of that would have been very, very severe. The planning assumptions in Yellowhammer were grim and extremely worrying. So we had no alternative but to do that work to the best of our ability. And we have limited resources. All governments have limited resources. Within emergency planning, we have within that limited specialisms and skills in particular areas. So it stands to reason that with so much effort on that, there was going to be less resource available for other aspects of emergency planning.
But resources were rediverted from a number of different parts of the Scottish Government. It wasn't, I imagine, that resources were only rediverted from civil contingency planning.
No.
You had to find the resource and the time and the energy from somewhere in order to be able to do the necessary preparations for a no-deal exit.
There was probably not, and forgive me if I'm slightly oversimplifying this here, but there would not be many, if any, areas of Scottish Government work that were not impacted by the planning for Brexit generally and a no-deal Brexit. So in health, other than emergency planning, a lot of resource and energy looking at some of the supply chain disruptions, the consequences for the health service staffing of ending free movement across the European Union, and education, obviously, with universities around the education programme. So every part of our work was impacted by this, and it was a matter of deep and extreme regret and frustration for us at the time.
The risk of a pandemic influenza was a tier 1 risk in the United Kingdom government's risk register. Presumably, it was no less greater risk in the Scottish risk register. It was identified as the greatest risk facing the nation in the plethora of risks which any nation faces. So would you agree that the diversion of resource and money and time from that issue, that area of planning for the greatest risk which the country faced, the tier 1 influenza pandemic risk, was ultimately a false economy, because although the consequences of a no-deal EU exit would have been extremely serious and had to be mitigated, the one area from which it really couldn't be said that resources should sensibly be drawn would be the no less significant area of pandemic preparedness.
I don't disagree with that. I think every aspect of Brexit has been false economy, if I can put it mildly, but that's another issue altogether.
Ms. Sturgeon, I'm so sorry.
Yeah.
That is a witness box, not a soapbox.
Indeed.
We cannot allow
Indeed.
the political debate of Brexit
Indeed.
to be ventilated here.
With respect, I think you're asking me questions here that are very germane to the whole issue. So yes, I think it was deeply regrettable that resources had to be diverted from any other area of work, and in particular pandemic preparedness. I also, though, would repeat a point I made earlier on, that it was certainly from the Scottish Government perspective, it was not the case that all preparation around the potential for a pandemic stopped. I would imagine you will ask me later in the session about Exercise Silver Swan. That
Yes.
was one of the key elements of work and different work strands out of that, of course. So all of that was deeply serious. The point I'm making is that we had little alternative but to do that. The consequences of a no-deal Brexit compared to what we faced with COVID, of course, pale into insignificance. But at the time, looking at the Yellowhammer assumptions, had they come to pass, they would have been severe. We were talking about availability of food and the shops and medicines for the National Health Service. So we had no choice but to do that planning. I deeply regret any implications that had for our emergency planning in other areas.
Thank you. That's very clear. Just turning now to the broad issue of the relations between Scotland and Westminster in terms of preparedness planning. Many of the recommendations which had come out of the Hine Review, to which you referred earlier, insofar as Scotland was concerned and the other devolved administrations, revolved around the need for a proper framework for communication, both at CMO level, the Chief Medical Officer level, and the DCMO level, the need for perhaps a health forum across the United Kingdom in which there could be a proper informed debate at that level about pandemic preparedness, and also, of course, between the civil services of the devolved administrations. To what extent do you believe that the working relationships in relation to pandemic preparedness worked across the devolved administration and UK level?
I think they worked reasonably well in general terms. I think they remained too ad hoc and didn't become, as the Hine Review would have recommended, more embedded in a very systemic way. I know, and this was certainly true at the outset of COVID, the working relationship between the 4 CMOs was very good and very strong, and Scotland's CMO at the time fed lots of information and thinking from those discussions into the decisions we were taking. Discussions and relationships between health ministers would vary, I think, from my perspective over the years, often, as will sometimes be the case, depend on the individuals concerned, which is more of a feature when they are ad hoc arrangements rather than embedded. Overall, though, I think in the context of intergovernmental relations, work around in swine flu and from swine flu leading up to the beginning of COVID, I think relatively speaking, they worked well.
Presumably, an informal system of communication depends too much on personal inclination, personal relations, and perhaps ministerial whim as to whether or not the meetings take place. Did you ever get to the point where you believed that there had to be a significant effort made to formalise those working relationships, or did it never get to that stage?
I think it frequently gets to that stage in various discussions, and in this context, yes, I think it would be better if we had working relationships that were more systemised and embedded, and that would then transcend different individuals. That said, processes will not work, however embedded they are, if they don't have good faith and the right mindset and attitudes behind them. So in terms of the working between the four nations in this context, or indeed any context, it's a combination of all of these things that is required, but certainly more of an embedded structure that is then respected by all of the governments at play, I think would be a step in the right direction.
Sturgeon, how do you get past, I don't know if you heard Jeremy Hunt come out with a brutally frank answer, which was that when he was Secretary of State for Health for the UK, for England and Wales, he found that party politics got in the way of the relationship between Ministers for Health in the various administrations.
So I think that can happen, and I think it has happened. I also think it's possible to overstate the extent to which that happens. In my experience, forgive me just briefly to go back to swine flu, as Scottish Health Secretary at the start of swine flu, Alan Johnson was Health Secretary for England, then replaced by Andy Burnham. I had a very good working relationship with both of those, and different political perspectives at play there. So I think if the attitudes and the mindsets are correct, particularly in the context of a health emergency, political differences shouldn't get in the way. But of course that is going to depend from time to time on the different personalities involved. And forgive me, I'm not going to stray off the topic here, but inevitably that will be influenced, it shouldn't be, but it will be influenced by the wider political context at the time. And perhaps Brexit has an impact there in terms of setting the overall tone for some of these intergovernmental relationships.
You lent your considerable authority to a review of United Kingdom and national intergovernmental relations, did you not?
Yes.
Post-COVID, there is now a structure which provides, I think, for a devolved government council, for interministerial groups to meet. I think there's an interministerial standing committee or some sort of committee, and a secretariat, intergovernmental relation secretariat. Do you know whether or not that committee structure has borne fruit yet? Is it something which, as First Minister, you attended whilst you were in office?
Those new arrangements are very much in their infancy, and were even more in their infancy while I was still First Minister. So I think in many respects it remains to be seen the extent to which they improve the overall working relationship. I come back to a point I made earlier. I think systems and processes are really important, but they will only work if all of the parties participating in them participate in the right spirit and attitude, and that in intergovernmental relations is often where it breaks down. And I've been, as First Minister, and for years before that as Deputy First Minister, involved in a range of different iterations, joint ministerial councils, these new arrangements, and they will work if everybody around the table is there in the right spirit.
My lady had evidence from Oliver Dowden, the Deputy Prime Minister, about how, but both before, but I think boosted by the National Resilience Framework in its publication by the United Kingdom Government in December 2022, there had been set up a UK resilience forum to discuss important issues relating to cross-United Kingdom resilience and civil contingency arrangements. The Scottish Government attended the first UK Resilience Forum, as did UK ministers, on the 14th July 2021. But the Scottish Government was absent. It's listed as an absent participant in May 2022 and February 2023. So it has simply not attended two of the three UK Resilience Forum meetings. Do you happen to know why that is so?
I don't know for certain that it is the case. I appreciate your read, but I understand there may be some dubiety about whether we were in fact present on one of these occasions, but that's not something I can answer for you with certainty.
Well, you were present on the first meeting.
The Scottish Government was present. I personally wasn't present. I understand from my own colleagues that there is some uncertainty as to whether we were present at the second one or not. I know the minutes suggest that we weren't, but that's not an issue I can resolve for you right now. That Resilience Forum, I think, is an important opportunity for the four nations to come together. Its remit, although again it's a forum in its relatively early stages, seems to be similar to, perhaps not identical to, the Scottish Resilience Partnership, which is also a strategic overview. So certainly the ability to have a Four Nations Forum that our own operations can feed into is certainly a useful one. I cannot answer why the Scottish Government, I can get that information for you. I can't answer here why we weren't present, if indeed we weren't present, but that is something I certainly would encourage ministers now to take part in.
Thank you. The minutes, I should say, both the 3rd of May 2022 and 23 do state in terms that the Scottish Government was wholly absent.
Can I say I wasn't questioning that particular point?
Now, the exercises, Silver Swan, Cygnus and Iris, the exercise Cygnus was a United Kingdom exercise delivered by Public Health England. It wasn't therefore focused centrally on Scotland. Scotland played an important part and attended it, and members of the Scottish Government were present during the exercise itself. Do you recall, whilst First Minister, debate about the extent to which the recommendations from Exercise Cygnus had been implemented? There is evidence, I should say before my lady, that on a UK level, many of the recommendations were, by the time of COVID, not implemented wholly. Some were in part implemented, some were not implemented at all, some were complete. What was the position with Scotland?
As I understand, so the first part of your question, would I have had an awareness? I would have had a general awareness of exercises and the Scottish Government working to implement recommendations that were relevant to us. I wouldn't have been closely involved on a day-to-day basis with that in detail. My understanding is that of the, I think, 22 recommendations out of Exercise Cygnus, the Scottish Government assessed all of them for their applicability or relevance to Scotland.
Yes.
And I believe at the time COVID struck us, there were 14 of those complete and 8 outstanding. Some of those would have been for the UK Government to take the lead on. I believe one on social care was paused by the UK Government due to Brexit, something we've already discussed. There was another around pandemic guidance that the UK Government was to take the lead on, but that hadn't been progressed. I think the other point I would make about this is, in relation to both those recommendations that I've mentioned, there would have been analogous recommendations in Silver Swan that Scotland was pursuing. So on social care, there was a recommendation there about social care contracts, business continuity that we had considered complete, and in terms of pandemic guidance, with one exception, which was updated guidance for health and social care that had been out for consultation at the end of 2019. But other than that, the recommendations in Silver Swan for updating guidance had been taken forward.
In relation to Exercise Iris, that was a one-day exercise. Was that a tabletop exercise?
Yes, it was.
And that was a Scottish exercise?
Yes.
In March of 18. Was that the exercise that was concerned with an assumed outbreak of MERS?
Yes.
And what, Ms Sturgeon, was the outcome of that exercise in terms of the implementation of recommendations?
That was very much ongoing at the time COVID struck. Obviously, that exercise was the latest of the 3 that we're referring to right now. I think took place in 2018, there were, I think, of the 13 recommendations in it, there were 4 that had been completed, a number, 2, I think, that were ongoing, and then some others were paused when COVID came along when we look at some of them for understandable reasons, because the system was dealing with a real pandemic at that time, and it would not have made sense to go forward in a separate track with the recommendations from IRIS. But IRIS is partly because of when it happened, is the one where at the outset of COVID there were most of the recommendations still outstanding, or more than in the other exercises.
I think it's fair to say, Ms Sturgeon, that there were no single work streams which were of great importance, which were wholly uncompleted. So, although there were, I think, 3 areas where work had not been completed, other aspects of those work streams had been completed.
Are you still referring to exercise IRIS?
Yes.
Yes.
So in relation to, I think, updating guidance in relation to MERS-CoV, which obviously is not of great significance perhaps in terms of dealing with COVID, certain work to do with readying NHS boards to deal with the potential impact of contact tracing and community sampling during a HCID outbreak, and also finishing off the fit testing for particular types of PPE. Were those the broad areas that were still outstanding?
Yes, that is correct. And some of the PPE recommendations around fit testing initially came from Silver Swan, but there were similar recommendations out of Exercise IRIS as well.
And then coming back to Silver Swan, which I acknowledge it was before IRIS, but the reason I'm coming to that last is for the importance of one of the work streams which came out of Silver Swan. I think of the 17 recommendations, 13 were considered by the Scottish Government to be complete, but an important area was pandemic guidance for the health and social care sector. Was that ever completed, even though Silver Swan was in 2015?
The specific guidance for health and social care had not been completed. It was out for consultation.
Specifically children from disadvantaged backgrounds.
Minister Marie Todd.
The Scottish Government meets with the Scottish FA frequently to discuss a wide range of issues, including the accessibility of the game.
Stuart McMillan.
Thank the Minister for that brief reply. The Minister will be aware